Que nadie lo conoce.
Perfecto. Entonces, yo creo que Chente, arrancamos y las
Okay.
presentaciones las hacemos, o sea, Patricio y eso.
Ok. Bueno, bienvenidos a todos al simposio de trauma ocular. Por favor, a todos los participantes que no vayan a exponer, por favor cierren su micrófono. Welcome everybody to Trauma Ocular Symposium. I'm going to ask participants to close the microphone. So, we can start, Luis and Patricio.
Ok.
Listo.
Luis.
Bueno, quiero primero agradecer a todos por su participación para este simposio. ¿Sí? I want to thank you to everyone to participate for this symposium of ocular trauma. Tenemos gente realmente de todo el mundo, ¿sí? Estamos desde Canadá, Argentina, Italia y Estados Unidos. Así que yo voy a dejar de dar paso ahora al moderador, en este caso que es el doctor Gerardo Malvecchia, y al director que es el doctor Patricio Grayer, para que presenten a los speakers y demos inicio al simposio. Muy agradecidos a todos por su participación.
Perfecto. Gracias, Luis. Thank you, Luis. Now I am going to present the first speaker, Dr. Federico Cremona. He's chief of the Department of Cornea of the Hospital de Clínicas José de San Martín. He's the chief in keratoplasty there. And so I would like, Federico, whenever you want, welcome to the symposium. You can start wherever you want.
Bueno, ahí estoy compartiendo pantalla. Avísenme si se ve y si se escucha.
Se ve y se escucha, Fede.
Gracias, Gerard.
Maximizala, que no estás.
Está en eso.
Okay.
A ver, ahí va. Bueno, muchísimas gracias por la invitación. I'm gonna try to give this lecture in English, just to see me for at least once. Thank you very much, Chente, that you are there, and all the participants. Well, my lecture is called Keratoplasty in Traumatized Eyes. So I'm gonna show some cases that I made. So this is a 44-year-old nice lady that had a car accident about 2 months ago. She had 2 previous eye surgeries. As you can see there, the iris was trapped in the wound or even in the suture that they gave. They sent to me just to repair, but when I was liberating this synechiae, what I saw is that the anterior capsule was broken. So we decided to make a can opener and let this lens, scattered lens, get out. So what we are doing here is just to protect the posterior capsule, and we saw a red reflex. The ultrasounds told us that it was a retinal detachment, so what we did is to put a temporary keratoprosthesis just to see what was in the posterior pole. So we put the trocars. As Gerardo always says, it's necessary to know how to put a trocar. There you see that the macula is damaged because of the trauma that this lady has. So we decided not to put TPA. That clot was old enough to put it, so it was not gonna be necessary to do that. And when we finished with the vitrectomy, I decided to put 3 pieces IOL and make an iris repair. So what we are doing here is putting some viscoelastic. I put the lens in that bag and then make the plastic of the iris. So that's what we are doing now. Maybe Ike is gonna show more interesting cases than this one, but I think it was fairly good. So we put 10 nylon sutures just to finish this case, and I'm gonna forward in honor of the time that was how it finished. Another case that I made, with the traumatized eye was, I showed this case before. It was a guy that has had keratoconus. He suffered from a trauma. Then his cornea started to swollen. So we decided to make a Valvecchia Jamane modified technique. That's for you, Gerard. So what we are doing here is to prepare the eye just to take out that lens that was in the posterior pole. So we are making the trephination. It was an 8mm trephination. And now the retina guys are trying to get that lens that was in the back. They put all the necessary stuff, see, perfluoro, just to lift it. And then they give me the honor to take it out. First, we took the K-Pro, and then we took the lens. Finally, we prepared the 3-piece IOL. This is a little bit hard. We don't have the tension, the necessary tension, but it's easier to do it because you can manipulate the lens easier. So we prepare the lens, we give some tone to the eye, and then I put the cornea and suture it. There's what I'm taking the tissue that is the remnants of the cornea. I'm gonna suture that cornea, and finally we prepare the lens and finally put with some tone. Then we lift the last trocar and suture it too. But things, we can do it, some endothelial keratoplasty also with traumatized eyes. In honor of the time we're gonna pass. Things sometimes goes wrong with this kind of eyes that has many problems. When they have trauma, it's a different eye. It's not as the same as a transplant, a regular transplant. What we are seeing here is an old lady that we managed to get that cornea for 10 years. It was only one eye. Then the cornea failed. So as you can see there, it has a rupture. So we decided to make, using the technique cornea over cornea, or in this case, K-Pro over cornea, we decided to make this case. We put some mannitol also, and just to keep that pressure down. As you can see, there is some vitreous going out from the wound. And although that we are suturing the recipient just to keep the eye closed, we are gonna have some problems. And so I'm gonna show you. This is the worst nightmare that we can have, also in the only eye. So we are now suturing the keratoprosthesis, the Boston K-Pro, and finally we are gonna take the other cornea from beneath. We took that, as you can see here, some vitreous is coming. We took that cornea and then repair all the cataract remnants that are in there. We use some scissors, and please look at here that there is a half moon or a moon going on. I didn't realize till this moment that it was really amazing. I asked for my fellow for a finger, give it to me, and I'm gonna suture it. So I'm having an expulsive hemorrhage. So we managed to control it, but this is the worst nightmare. I suture the K-Pro. And although I made all the necessary steps to manage this case, this old lady finally had a choroid detachment. So this is, I think, my worst case. I'm sorry for my English. Thank you very much.
Thank you, Federico. Very interesting. Yes, that's a nightmare for everybody. It's like really the worst scenario for a corneal surgeon. I know, Ike, you want to say something about these cases of expulsive hemorrhage?
Well, I mean, the scenarios that Federico is sharing with us, and I must say, I mean, what you're seeing is a very humble surgeon. Federico is a fantastic surgeon, and he always gives other people credit. Just so you see this, I think this is something that we can see in many cases, and it's multifactorial, of course, systemically controlling the patient's blood pressure, having patients stop their blood thinners. But whenever we have an open procedure like Federico showed, this is always the moment of concern. And so I think that I try to do as many manipulations as I can in a closed system environment, including again, a temporary keratoprosthesis as you showed. So I think you manage it as best as you have, and even all of us have experienced these situations. And again, when you do a penetrating procedure like that, this is always a risk that we face.
Yes, Federico. What do you think you would have done different? You know, it was like talking to the anesthesiologist and try to keep the blood pressure pain, you know.
We made for 1 hour and a half some massages, right? It was a peribulbar, not because I wanted that, because she has heart problems. So we made that. I always use, here asking about the Flieringa ring, I always use the Flieringa ring. So in that case, it was a large Flieringa ring. I use it on purpose. But today, I realized that it was everything done, and it was the destiny.
Yeah, okay.
Yes.
I would like to add just some comment. Okay, it happened to me the same, Federico. So we are brothers in pain, right? And also during a corneal transplant, an open sky technique, and that moment I have also a expulsive hemorrhage. Okay, and what we did is just pressure with 3 cottons directly on the eye, okay, for 5 minutes. And also we must remember that many of these cases correlate very well with the pressure, okay? But these patients take a look always and ask to the cardiologist or ask to the anesthesiologist to look for that pressure. These patients increase the pressure and then start with this hemorrhage. So we have to take care of 2 things: the pressure and the hypotony of the eye. I think that's 2 things have to manage, especially in this case. But excellent presentation, Federico, like always.
Thank you very much.
Well, Gerardo, yes, would you please present your friend Ike?
What's that? Oh, yeah. But I present again in Spanish because there is a lot of Spanish people talking. Only you talking English. It's okay. But, well, Ike is one of the greatest surgeons in the world. Es uno de los mejores cirujanos de segmento anterior y posterior del mundo. Realmente, cuando uno lo ve, aprende y lo admira. Y yo he estado muchas veces al lado de él en quirófano y he tenido la posibilidad de ver cómo piensa también en cada momento, porque lo que hace un buen cirujano es decidir sobre la marcha. Y Ike es una de esas personas donde uno aprende muchísimo. Ike, all to you now.
Oh, gracias, Gerardo. I don't know what you said, but
No, don't worry. I think it's Spanish because if you understand me, you cry.
I think I heard something about being racist or something. Is that what you said? I don't know. I hope it wasn't. Okay, well, again, gracias. Thank you so much, for the invitation, everybody. It's great to be with my Latin American friends as well as international friends. We've been doing webinars for quite a while now, but it's been, now a little bit less common with everybody being busy, but I really enjoy being with the group. So I'm looking forward to everyone's presentation. The topic is ocular trauma, and I will try to share with you at least one case, maybe another case if we have time, just to show managing multiple anatomical injuries at the same time, which many of our patients do suffer. I'll use this as the first example here of a young female with an airbag injury, and this patient has multiple issues. They have a cyclodialysis cleft, which has created hypotony maculopathy. There's vitreous in the anterior chamber. There's an atonic dilated pupil. There's dialysis with dislocated cataract, and there's a cataract as well. So we have multiple issues in this patient. The only good news is the retina was attached, the cord was attached, and the sclera was intact. So that's good news. And for Federico, the cornea was okay. So we don't have to worry about the cornea right now, at least. These are some publications we had published, and I see that Juan Mura is with us and others. We published a series of managing these. And our general approach has been that, when the clock hours start to go beyond 3 clock hours, we try to laser. I've generally found it to be relatively unsuccessful. For 1 or 2 clock hours, lasering can work. But I typically approach this with an external cyclopexy. One can use the capsular tension ring in the sulcus as well for internal tamponade. We've done this as well, and we reported this. But my classical approach, as we're going to show you, is to manage this with external cyclopexy. Because of vitreous in the anterior segment, we generally place a trocar. I agree with Federico and Gerardo with what they mentioned, and some triamcinolone is helpful. Now, do this before the viscoelastic goes in the anterior chamber to ensure that the canalog can get to the vitreous. And you can see we did some pars plana to decompress a little bit, and then we have the sheet of vitreous present. This is the first approach because we, of course, want to make sure that we amputate the vitreous. We reduce the risk of traction with manipulations, and it's nice to have anterior infusion and go both in the anterior chamber and the pars plana to shave off the vitreous from the anterior segment, always making sure we keep the anterior chamber formed throughout the manipulations. It is very helpful in this case to have an intraoperative gonio mirror. This is a double mirror, as you can see, and we mark the extent of the dialysis. One can use an indirect mirror or a prism, but they're not as user-friendly as using a double mirror. This was a DVX lens from Ocular Instruments. The next step is we're going to be placing the dislocated lens. These MST capsular retractors, very useful to use in a bind, and they are helpful to support the capsular bag in the areas of the zonulopathy. This particular lens was not very dense, and so we're able to manage this with basically more phacoaspiration than anything else. And we're always making sure we're keeping the chamber formed before pulling out, and the IA is done. Again, notice how stable the bag is. Now we will remove these MST retractors. It helps to do a reverse removal, making a groove incision about 1.5 back from the blue zone, or about 2 millimeters or so from the limbus. And now we have the capsular tension segment that we're going to use to support the capsular bag. Now, there are many ways to, of course, put a lens in. There are scleral fixation techniques without using the bag, using the bag with other techniques and sutures. I still do like to maintain the capsular bag and use capsular devices within the endocapsular space. And Gore-Tex suture for us has been the preference as far as longevity. I generally put a CTR in as well for circumferential support, and then IOL can go in nicely. And then you can see that the iris can be manipulated. Now, we are going to now pay attention to the cyclodialysis cleft. We're making a partial thickness scleral groove. This starts about 4 millimeters back from the limbus and basically approaches to the insertion at the limbus. Then we go back here, in this case, about 1 millimeter back from that zone. And here we're basically making a full thickness scleral cut down. This is basically the area we're going to be reattaching the ciliary body to the sclera. This is obviously a little bit of a larger section. We sometimes need to do smaller and large ones, but this is important to be able to pass the suture. I am using here 9-O-proline. The needle is not optimal. It's designed more for suturing in the eye, but you see we bent the needle to create more of a curve on it to both imbricate the iris within the anterior and posterior lip of the sclera. I tend to make the scleral cut down a little bit posterior. I don't want to be entering in the anterior chamber and reattaching the iris to the angle and potentially result in angle closure. And so we basically aim back a little bit. Like I said, if we identify the blue zone, which is typically the anterior trabeculum, if you go a millimeter back from that end of the blue zone, this will put you approximately basically where the iris insertion should be. We did multiple mattress sutures here to close that cleft. You can see passing it all along the circumference of the cleft and sequentially closing this. It's amazing how little the ciliary body bleeds. We are working over the ciliary body and we're avoiding full thickness passes through the ciliary body. All we need is a small grab of this, and it's something that is quite surprising often in terms of why we don't see this bleeding. But again, I think it's fairly safe to work in this area. We then will close the sclera later on. But what we're doing now is basically finalizing the suture tension on the CTS segment. And finally, we have to also address the iris. And this patient has an atonic, generalized, dilated pupil. And what we typically do is essentially use a pupil Serclaw suture. Now, this is basically using a running suture passing over and under the iris here to basically create a purse string closure. This is using 10-O-proline here rather than using 9-O. 10-O tends to be, I think, less likely to create buttonholes. And using a micro forcep, I think, very helpful to allow us to grab the iris and pass it along. This is done in 4 quadrants. And then we have the continual pass. I like to use micro tires to tie this. And we typically go for about a 3.5 millimeter pupil size to reduce the risk of photophobia, but still allow our retina colleagues to allow us to still visualize the retina. Finally, we'll use some tissue glue to close the sclera. And this allows us to, again, get a nice closure. These are big surgeries, like I said, manipulating vitreous, lens, iris, ciliary body, all in one case. This is one picture that we see postoperatively. Let me just go to one more case on the other extreme. This is a traumatic case of a traumatic cataract and traumatic glaucoma with a pressure of 40 in atonic pupil. This is the other example, the other extreme, where we have significant outflow dysfunction and a very dislocated cataract. Now, many of you have seen different approaches in terms of how to manage these cases. This lens, to me, still has one zonule, so we must pay respect to the one zonule and give it the chance to be able to still hold the lens in the capsular bag. We'll do a vitrectomy, and this is basically using an anterior levitation technique, something that we've used in many cases now, to levitate the lens with scleral depression, bringing it up behind the retropupillary space, and using a pair of microforceps to initiate the capsulorhexis. This is kind of all in one: levitation, capsulorhexis, and propagation of the tear. And it is helpful to have the iris hooks present. Now, of course, I don't have to use a capsular bag. I do think the capsular bag is a great place for the lens, although I could certainly go sclera as another alternative. Of course, we probably want to avoid an anterior chamber lens in these cases of traumatic anterior segment injuries. We are handing off the capsule to another hand and using, again, iris hooks to support the capsular bag. This is, Juan Mura was probably on the line here. He may remember as a fellow doing these cases. Juan, you may remember these cases we did together, where we managed these cases, severe dislocations, and even Juan, we know how bad he is as a surgeon. He still was able to manage these cases. I'm just kidding. So we have a good capsulorhexis. We can basically place one capsular tension segment in this case, a second capsular tension segment on the other side. And here, rather than using the MST capsular retractors, I'm using the segment here to support the capsular bag with an iris hook. And this is placed inverted to hold the bag in place. We then place a CTR in, and we really have great control of the bag here as we do this. And I often, as I've said before, complexity is simplicity multiplied. We have complex problems, multifactorial, multiple anatomical injuries. But if we simplify each part of this into discrete steps, we can perform them and execute them well and be able to put together this complex situation in one. We will then do our scleral passes. I showed it earlier using the Gore-Tex suture on both sides. We have the IOL secured in the bag, and we are good to go. This patient, of course, also has an atonic pupil, and I've already showed you the cerclage. Just notice a couple of things. First of all, double-armed, use the forceps to bring the iris to the needle rather than the needle to bring it to the iris. And even though this is a very atonic pupil, if the iris is still intact and not torn or damaged, I can stretch the iris considerably and suture it back down. And I do love this, and I know Matteo and I love prosthesis as well, but I do like to suture the iris if I can. And cerclage is a beautiful technique using both hands to go all the way around and to close. And finally, of course, we must remember the patient has a very high pressure. We're placing an Ahmed valve into the supratemporal quadrant, and we're going to use a scleral tunnel to place the tube into the anterior chamber. So my point in this exercise is, again, multiple comorbidities, multiple anatomical injuries, whether it's low pressure or high pressure, but managing everything together isn't necessary. But I like to do it all in one surgery if we can, using, again, a less invasive approach, minimally invasive approach, managing all aspects of this case with hopefully a reasonable outcome. So thank you very much for having my invitation. I look forward to the discussion and for the rest of the presentations. Thank you.
Amazing, Ike, what you did with that eye is incredible. I think there's nothing to discuss here. It's really amazing what you did. I don't know. I think any mistakes.
You're great, man. In the first case, it's probably the astigmatism.
I actually didn't pull up the result. This patient actually surprisingly did very well. But you're right. Sometime with that closure, even though it's farther back, you do get some cylinder there.
No, you're great. Great.
Maybe I should put toric lens in for that case opposite, or something.
Okay. So I have one question. So what happened when you put like these segments, with this, do they cause pressure on the opposite zonulas long term?
Very good question. And that's why if I worry about zonulopathy, diffusely, I like to put two segments in, because over time, the remaining zonules may become a problem. This is particularly important in pseudosfoliation. In traumatic cases, when the rest of the zonules are very strong and it's non-progressive, as long as I don't tie the suture too tight, which sometimes is a mistake, I believe it's stable. And that's why I like to use a slip knot to very carefully adjust the tension. And we've had very good results with a single segment. The majority of our cases, in about maybe, I think we have 1,200 eyes with segments implanted over about maybe 13 years now. Majority are single elements. And you're right, in some cases, we see the remaining zonules over 5, 6 years, 10 years start to go away. That's usually in pseudosfoliation or in congenital cases. But traumatic cases, I feel, generally speaking, we're protected by having the remaining zonules intact if they're good in the first place.
Yeah, Ike, it's Matteo. Really great presentation as usual. I really like the way you do the iris cerclage, and I agree with you, because even if I talk a lot about iris prosthesis, of course, when it's possible to do iridoplasty, it's always the better choice. Just a question about the suture for iris cerclage: Prolene or other solutions?
We have tried a few different solutions, including Merceline. I still use Prolene. It's readily accessible for us. There is some degradation by UV light in some cases. And so we have some cases where actually we have some breakage. But the majority of cases have lasted a long time. So you're absolutely right. Sometimes I think what happens is that the iris gets fibrotic almost. And even though the suture itself can break, the iris often stays reasonably well, as long as there's not too much tension on it. But we need a better suture, Matteo, right? We are working with Gore-Tex to provide a 9.0 version of Gore-Tex with a proper needle. We'll see whether that meets the light of day. But until now, that's what we have used. But I'm open to other suggestions for other sutures. If it's too thick, though, like if you use 6.0 Prolene, that's way too thick, right? It's going to end up cheese wiring the iris and damaging the iris tissue.
Yeah. So you think that Gore-Tex could be good even in iris cerclage? So you have Gore-Tex all inside the anterior chamber. Can be good?
I think it'd be fine. The problem is the Gore-Tex we have right now is too thick, 7.0 equivalents, too big. That's the problem right now. So we're working on a new Gore-Tex, I hope.
Yeah, it's an open question.
Okay. I want to share to you a little video in Spanish. ¿Puedo, Chente, ahora?
Claro que sí.
Vamos a invitarlos a todos a participar al video simposio que vamos a... para que algo está... Ahí estamos. Ok.
Es la segunda parte, ¿verdad?
Sí.
Para que manden sus videos, va a estar muy bueno. Ahorita Gerardo nos va a poner el video de...
Siempre y cuando funcione. Ok. No, gente, ¿me escuchás? Sigan
Sí,
adelante,
sí, claro.
después comparto.
Bueno,
como no es mi computadora, tengo que hacer todo de vuelta, así que sigan adelante.
Bueno,
Ahora entro de vuelta.
Ok, entonces continuamos con María.
Maria, we will continue with her. He is our friend Soledad. He was resident of my hospital, and then he went to...
No, porque me salir del
where now he is leading his Precision Eye Care. He's founder and director of that nice clinic, and we are very pleased to have you here, Sole.
Okay.
Whenever you want.
So, okay, thank you so much. And it's always a pleasure, to work with my mentors in Argentina and to, continue education on these times. So I'm going to show a couple of cases. I've been private practice in Baltimore, so I don't have, like this huge trauma, like very, very severe. But I will refer things, and I hope, you can take some tips. So the first patient is a gentleman that just have a sudden trauma in the head, and he, noticed a decrease in the vision. The only, history is that he had cataract surgery and a capsulotomy. And you can see on the image on the right that the one piece IOL is dislocated later. So my approach is, should I reposition this implant, or should I, do an IOL exchange? I can reposition it one piece if the capsula, if the capsula is not intact. So I opt to do exchange. I like for my IOL exchange with the capsula, but especially those cases that don't have capsular support, to do a technique that was described by Agarwal, that is the scaffold technique. And a scaffold means barrera, builds platform, and the goal is to insert the lens in the eye, the new lens, before removing the old one. So you can see I diode the lens outside the eye, I put the new lens, and then with microforceps, I remove the lens. And I will tell you what are the advantages of, putting those implants in the eye. So this is the technique. And on these cases, I usually like to perform a vitrectomy, a pars plana vitrectomy, to release any vitreous strands prior to manipulate the implant. So I use an anterior chamber. I don't have any preference in the anterior or posterior. And I noticed that sometimes, some surgeons do manipulate the implant and they try to clear the vitreous after, at the end of the surgery. But we have to keep in mind that now when we are manipulating the implant, we can pull, the vitreous and cause a retinal detachment. So, like very, clean anterior pars plana vitrectomy before mobilizing the implant. The implant is dialed into the anterior chamber, and then I expand the sulcus with visco, and the new implant, in this case a 3-piece, is inserting underneath. This implant, it will help in many ways. First, it will prevent any vitreous prolapse to come into the anterior chamber, even though with the anterior chamber might turn, because there is like some changes in the pressure. And also, it will allow me that when I dissect the new implant, some, no piece of the implant will fall into the back of the eye, and also give me a little bit more of anterior chamber stability. I usually prefer to dissect into the implants and just remove them through a small incision. Sometimes when I do the IOL exchange, I don't have to put a suture. On this case, I did because of the anterior vitrectomy. So patient was like 2040 the day after, and it's a case that if you don't take the appropriate steps, it can be complicated later on with a long process of corneal edema or CME, and further problems. So my tips for these surgeries and how to obtain a proper recovery of the patients is to keep the, the good pressure in the eye with anterior chamber maintainer or posterior. And then I like to use like micro instruments, micro scissors, and micro forceps to manipulate the lens in the anterior chamber. I think is a key for these cases that are simple, but can get complicated to have the proper equipment and plan, accordingly. And one, for the anterior vitrectomy, we all know, I prefer the pars plana approach, and the settings is high cutting and low vacuum settings. And always, when you are performing the anterior vitrectomy, just to avoid to pull the vitreous when you are cutting, okay? So stop cutting and then move to the next step, because as an anterior segment surgeons, we are used to pull the lens toward the incision. And that's when the high incidence of retinal detachment and CME on these cases occur. And the next case is a patient that have a standard cataract surgery, except that at the end of the case, it was complicated with an iridodialysis. And the surgeon just left the case like that. So you can see the iridodialysis that is for clock hours, and the D-shaped pupil. And I do like to perform like a technique. It was described by Michael Snyder. And this technique is called appositional. It's not playing? No? Oh, okay, there we are. So I perform a peritomy, and I use the curved needle with 1009, and I perform 2 paracenteses parallel to the small iridodialysis, and I go through the paracentesis, grab the full thickness of the iris, and come out like about 1 to 2 millimeters behind the limbs. With the other extreme, I use the same paracentesis, and I grab the other edge of the iris and coming out. And then I proceed with the like matrix suture. The difference is that in this technique, there is like an apposition of the iris root to the sclera, and it doesn't cause like a, how can I say, like folding of the iris and decrease of the pressure. Okay, are we good with time? Yes. Then I do like a regular, like double knot. I suture, make sure that the pupil is in, like the shape of the pupil is fine, and I just burn the sutures into the sclera. And the most important thing, just being gentle with all these steps that seems easy, but they can be complicated with moving the lens or having a vitreous. And I use like 10-0 proline on these cases. And then I just remove all the viscoelastic from the eye. It's very important to always coat the endothelium with viscoelastic to prevent corneal edema. Some people do prefer to use a cannula to guide the suture in and out of the eye, so you don't like grab the, like a piece of the cornea or some of the tissue during the procedure. And I always add a myocol at the end of the case. That's it. Nice. And Patient was very grateful. And one of basically the tips for this, and you can repeat and you can use this technique when you have like larger either dialysis repair, you just do like 2 or 3 segments. So, and this is what's done with topical, okay? Just continue to replenish the lidocaine, just make sure that there is no vitreous in the area, and it's very important to have a suture that is good quality. So when you don't have to keep re-grabbing and, and damaging the sclera or the iris and causing pains of the patient. Okay, wonderful, that's it. Simple, thank you. Professor.
Excellent.
The legislature is not.
Beautiful cases, really.
Thank you. Gentle, thank you.
Deja de compartir. Ahí está, perfecto. Buenísimo. ¿Algún comentario respecto de los casos? Más que nada para los chicos jóvenes, está bueno la primera maniobra que ella hace, que también la hemos visto hacer a Agarwal muchas veces, de poner un lente intraocular, le da como un escudo, que está buenísimo, para después poder trabajar tranquila. Es una maniobra sencilla y es muy práctica para algunos casos. Porque, a ver, a mí me ha pasado más de una vez que cuando quise cortar un lente intraocular, sin querer tocaba con la tijera la cápsula posterior, y bueno, y todo se complicaba. Entonces, realmente me parece una maniobra súper, súper útil para estos casos. Federico, ¿algún comentario? Patricio.
Sí. Did you do reverse capture in the second
No, I did not. I should have done, but I didn't. I should have done. Yeah. Good point. Because it's something that I always forget, and also the scaffold technique, it helps me a lot in the situations where I have an anterior capsular tear and the cataract is very dense and I don't know if it really extends to the back, that you say, okay, did I break it? Did I know, So in those cases, what I do, I put visco, pull the lens anterior in, just put the lens underneath. So I know that I can go and phaco, still a little bit parallel to the limbus, but I'm not going to, enlarge the vitreous. You don't know how many times that scaffold technique helped me and how my PCR, the posterior capsular rupture went down since I incorporate that. Thank you.
Excellent, Sole. Now,
¿Se me escucha? Gente.
Sí, se te escucha y se ve tu pantalla.
Gente.
Sí, se escucha y se ve tu pantalla.
¿Se escucha y se ve? Bueno, pongo el videito si les parece, a ver si me deja, a ver qué es esto. No sé qué me es esto. Bueno, decime si anda, gente.
Dale.
Perfecto.
Hazlo
¿Se ve el video? Bueno. Para invitar a todos al segundo Film Festival de Faco Extrema. Es 80 más que nada, estamos recibiendo los videos. En el primer concurso recibimos 93 videos de todo el mundo. El Chente Molina ha llevado uno de los premios galardonados y bueno, esperamos sus videos. Seguimos adelante con el curso. Patricio, todo tuyo.
Dr. Belvecchia. I would like, Ike, do you have any comment about Dr. Romero cases?
Yeah, I think they're very good comments. I do sometimes struggle with when you have a lens dislocated and it's in vitreous. How do we make sure we don't pull without ensuring the lens is completely free, right? Because visibility is a challenge. It's it's behind the iris, and you're doing so. I think it did the right thing by doing a pars plana approach, but I'm always really cognizant and mindful that am I sure that the lens is completely free. And so my general rule is, I mean, the vitrectomy does have to be performed a bit blindly in the sense you can't see where the cutter always is. Iris hooks can be useful to really, really get the iris opened up so you can see the lens, and really make sure that you cut the vitreous around the lens. If the lens is pulled, and if the haptic is still attached to vitreous, you're pulling the vitreous base. That can be very dangerous with a giant retinal tear. So I generally don't pull the lens up until I feel the lens is basically like floating like this. If it's floating like this, I see the haptic. Otherwise, if I pull, the haptic may still be engaged in vitreous, where it probably is. So that's where I do often, bring my biome in. I will look at the peripheral retina. I will scleral indentation to look and have a view of the haptic as I'm trimming it. That's the only thing I would be careful of, in just that sometimes that trailing haptic is still stuck in the vitreous. That's only my comment on that. But we often do get away with less visualization.
Mm-hmm. No, that's a very good point, because if you look at the reports, I like IOL exchange a lot, and if you look at the reports, the rate of complications is very high, and every time that the patient has, you have to do an IOL exchange, there's complications. And if you look at the data, it's vitreous detachment and CME. So I always trying to think, okay, how can we avoid? Because it's not so difficult. It makes sense, and you made a very good point. Because as soon as you pull the vitreous, you have retinal detachment and then the CME. Make sense? Good. Thank you.
Good cases, very nice cases.
Thank you.
Bellissimo, bellissimo.
This is Italian.
Oh, sorry. Matteo's here.
Talking about Italy, I would like to present next speaker, Dr. Matteo Forlini. He's a well-known vitreoretinal surgeon in Ravenna, Italy, a very nice place. I think that he is the Italian version of Ike.
No. I'm not like Ike, but I would like.
No, you are far surpassed me, my friend, and you definitely have much better looks, and you are dressed nicely, and you're well groomed. Don't look at me. Don't look at me. Look at my picture now. Much better.
Well, so thank you.
Oh, what's pretty, man. You're crazy, man.
Thank you for the invitation. It's a pleasure to be here. So I'm going to start with my presentation, and I am talking today about how to use artificial iris in post-traumatic aniridia and aphakia. As Ike said before me, he said, of course, if we have enough iris tissue, we can do iridoplasty technique, of course. And I am a huge fan of iridoplasty technique, like Sipser, sliding knot, or iris cerclage, and many other techniques. But what do we have to do when we don't have enough iris tissue present, like big partial aniridia or complete post-traumatic aniridia? So we have to choose in this situation for prosthesis of artificial iris. And we have three possibilities nowadays. Everybody know the Morker aniridia implant with IOL, then human optics artificial iris, and the newest one is Rapper artificial iris. So just a very fast comparison. So Morker is of course the cheapest one, very cheap, and that's why every surgeon has Morker probably in its hospital, because it's very cheap, and maybe it's the only option in public hospital usually, at least in Italy. But it's not very good for cosmesis because only black color, no iris detail, and we have IOL inside, but the incision is very large because it's a PMMA, so you need a big incision, more than 12 millimeters, because it's not non-foldable. So you have to enlarge a lot. And you can also have, you can obtain segments but anyway, it's not very easy to implant, but it's very cheap. So this is a good option, not in public, but not in private, maybe. Human optics, on the other hand, is the most expensive. It's more than 4,000 euros, almost 5,000 euros. So the most expensive one actually is excellent for cosmesis because it's individualized to match the other eye, because you need the photography of the other eye. You send the picture to the factory in Germany, and they prepare the artificial iris with the same color for that patient. So it's very, very nice, but very expensive. And you don't have the IOL inside. So you only have the artificial iris, no IOL. So if you want IOL, you need to suture the IOL on the back surface of the iris. The small incision, because it's foldable, so you can open the cornea only 3 millimeters. So this is a good point because it's foldable, so you need a small corneal opening. Wrapper is in the middle because it's cheaper than human optics, but more expensive than marker. Nowadays, at least in Europe, is 2,000 euros with IOL included, or 1,300 euros without IOL. So it's very good for cosmesis. It's not custom made, but you can choose more than 300 colors options. So it's like you have a catalog of many colors. So we have good iris detail, and you can choose the best color for the patient. Incision medium, because it's foldable, but if you want to implant the artificial iris with IOL included, it's not so foldable because it's quite big prosthesis. So you can try in the cartridge, but in my experience, when I implant the artificial iris with IOL included, I prefer not to use the cartridge, but I just fold in the half and I put inside. So I have to open maybe 6 millimeters, something like that. I will show you in the videos. So I just present you 2 cases. First case, 38 years old male, but very, very old trauma. 20 years ago, when he was a teenager, he had a big trauma, blunt trauma, and as a consequence of this old trauma, he had traumatic subluxated cataract with zonal dialysis and mydriasis. You can see in the picture up. And actually the problem is that this patient came to our clinic now, last year, when he was 38 years old. So you can imagine this situation was like that for 20 years. So the iris, this mydriasis, after 20 years, it became very fibrotic, very rigid iris tissue. So not possible to do iridoplasty. That's why I tried, but I couldn't do it. So I had to convert the option to artificial iris prosthesis. I will show you the video. So this is my first operation, and you can see the big mydriasis with this subluxated cataract, traumatic cataract. At the beginning, I tried to do a normal phaco, a pseudo normal phaco. So I just stained with trypan blue the anterior capsule, and I'm trying to perform a capsulorhexis. Actually, I didn't have the hooks to hold the capsule. Of course, Ike Ahmed just show us how the hooks can be useful in these cases, but really, I didn't have it at that time. So, I mean, maybe it was better to use it, but my fault. So I just tried to do the phaco. The lens was very soft, so no problem, just aspiration. And the problem was the bag, because you can see the bag was very, very subluxated. So I managed to do this phaco without breaking the capsule. So now I'm removing the epinucleus, and then I will remove the cortex remnants. But you see, I'm removing the cortex remnants, but the capsule is intact. the posterior capsule is intact too, but it's very, very subluxated. So actually, without the Hamed segment, the capsule tension ring or the segment tension, capsule tension segment, I prefer to remove actually the bag, because I was thinking already to do an implant for the iris and for the lens. So I converted my mind. I just prefer to remove all this bag and prepare for the scleral fixation. Anyway, I just tried. I'm doing anterior vitrectomy with triamcinolone because, of course, we always have to remove traction of vitreous, as Ike told before. So now this was my last attempt, because I just tried. You never know, but this was just to show how difficult, how impossible was the iridoplasty in this patient. So I just tried to unroll the tissue. I'm just trying to pull the tissue with my forceps, with spatula, massaging, but you can see this iris tissue was too rigid, too fibrotic. So all the usual techniques of iridoplasty was not good, was not efficient. So actually pulling the iris tissue, I was causing iridodialysis. So, you know, I'm just trying. So actually this video is just to show that sometimes it's not possible to do it. So at the end, I was thinking, okay, maybe I try to do a Sipser sliding knot, just to try. Maybe with the suture I can make a narrow pupil. But you can see this is my last attempt. ProLint and 0. This is Sipser sliding knot technique. I usually like this. I like this technique. It's very, very good. But in this case, was not good, of course. So I just try, and when I pull the suture to close the pupil, you can see now the tissue was too fibrotic, too rigid, and you can see it breaks. So this is the proof that it's not working, of course. So you know, I was in this public hospital, so. Actually, I was trying to do that because this procedure was free for the patient, because artificial iris, it's for payment. So of course the patient preferred not to pay. But after this attempt, I said, okay, I'm sorry, but I cannot do that. I cannot do that. So I have to.
Intanto facciamo una carrellata sulle nuove sale.
This is the same patient. After some months, we decided to order artificial iris by Rapper.
Mi fa d'aiuto?
This was
Vediamo le immagini, regia.
Surgery last year in Italy.
Ecco,
So,
mi sembra.
This is the same case after 5 months, and now I'm preparing.
Insomma, ho avuto un trauma 15 anni fa.
The artificial prosthesis by Rapper. So. Actually, basically, it's like a scleral fixation, 3 points. So I'm preparing the scleral flaps at 12 o'clock, 4 o'clock, and 8 o'clock. I am sitting at 12 o'clock position. So here I'm preparing the 3 scleral flaps, and I open the conjunctiva. Of course, there are many different techniques for scleral fixation. So this is my approach, but you know, there are different approaches like Hoffman pockets. I'm using here ProLint and 0, but we said that Gore-Tex suture is another option, very good now. So, I mean, this is just an option to obtain a scleral fixation. You just have to remember the Rapper prosthesis, artificial iris. It has 3 small holes. So it's very easy because you already have the 3 small holes and you just pass the suture in the holes. So you just have to be, you can see now, this is the prosthesis, the IOL is included. This is the history again. As I told you, we had this traumatic cataract, we had this big mydriasis, and it was impossible to close the mydriasis with the iridoplasty technique. So just to remember to put the suture in the hole, of course. Here I'm using Prolene 10-0 curved needle with a loop, you know, the loop suture. So I like that because I just pass the suture in the loop itself, so it's very easy to prepare. I just opened the cornea about 5.5 millimeters here. You can see I just folded the artificial iris in two, in half, and when I am in the anterior chamber, I just leave it, and you see artificial iris opens. And I am using anterior chamber maintainer. This is 25 gauge anterior chamber maintainer. I love using anterior chamber maintainer in these cases because I can control the ocular pressure and I can control the bleeding. Sometimes you can have bleeding. So I like to use anterior chamber maintainer better than viscoelastic in this complex procedure. And now I just fixed the 4 o'clock and 8 o'clock suture. And the last step is fixing the 12 o'clock suture. It's easiest because I'm sitting at 12 o'clock. So for me, it's easier to position this suture at the end. And that's it. Of course, you have to pay very attention to obtain a good centration of the pupil. So before closing the suture, you just have to pull a little bit on the right, a little bit on the left, of course. But now I'm just closing the corneal wound with the nylon 10-0, and that's it. This is the end. Oh, you have to pay attention to put the artificial iris behind the original iris remnants. You can see the iris remnants, the original iris tissue, and you can see that the artificial iris prosthesis now is a little behind the original iris tissue. So it's positioned a little posteriorly to the original iris remnants. That is very important because if you put it anterior to the original iris remnants, you can provoke a closure of the angle. And so secondary glaucoma, and you know, of course. So this is the patient 7 months later, and you see the cornea is still transparent, the pupil is well centered, and you can see the original iris remnants anterior to the artificial iris prosthesis. So if I have time, second case, if you want, or it's okay, I don't know. Okay.
I think, Matteo, you can go. Yes.
Okay. This is my last case. Second case, 55 years old. He had a severe ocular trauma with corneal wound and post-traumatic aniridia and aphakia. So first time surgery, corneal suture, you can see in the picture, but the corneal wound in this case was very, very severe. So you can see the suture was everywhere in the cornea. So in this case, I had to do PK, of course, corneal transplantation and vitrectomy to remove the lens luxated in vitreous chamber. The only good news was the retina. The retina was still attached. It was a miracle, but it was attached. And then again, a third time surgery for artificial iris implantation. So you can see the video, you see the cornea was destroyed. So I had to plan the PK. So again, you saw it in the first presentation of this webinar, but again, I present a similar case. So corneal transplantation, PK, and I'm positioning now temporary keratoprosthesis by Eckert. You know, I am preparing the temporary keratoprosthesis by Eckert, and I'm fixing it with Bickel suture. So, you know, this is TKP. And now vitreous chamber. As I told you, the retina was attached. It was a miracle, but you can see the lens. So the crystalline lens was luxated in vitreous chamber. I am using triamcinolone to stay in the vitreous, of course, and I want to perform a complete vitrectomy. You know that in these severe cases, you always have to perform a very, very complete vitrectomy with vitreous-based shaving in the extreme periphery. So I really, of course, usually I dedicate a lot of time in this cleaning of the vitreous. And after that, I'm removing the crystalline lens. Fortunately, it was soft because the patient was 55 years old, so the crystalline lens was soft, was easy to remove the lens pieces with the vitrectomy. I'm using here a 23 gauge vitrectomy system. And now I'm completing the vitrectomy in the extreme periphery with the vitreous shaving. I'm removing the blood clots, and you know, the visualization is very, very good thanks to the temporary keratoprosthesis. And with indentation, I usually in these cases, I love to use the chandelier. I'm using chandelier 27 gauge twin light. And this is very helpful for me because I just do by myself. So I do indentation by myself, and with one hand I do indentation, and with the other hand I do vitrectomy. So I like to use chandelier system, light system in these complex cases. I prefer to indent by myself. I mean, I prefer, it's more comfortable for me. And so I'm just completing the vitrectomy. I'm just performing endolaser 360 degrees. In our strategy in these complex trauma cases, it's always to do 360 degrees endolaser. And now I finished vitrectomy. I'm just removing the temporary keratoprosthesis, and I'm just completing the PK with the final corneal graft positioning. So this is the final suture, of course, of the cornea, and this is the end of the surgery. So the retina is still attached, and I just do the final exchange with air. I always like to finish the vitrectomy under air and not underwater, because I prefer for hemostasis, air is very helpful to control bleeding and to control your blood pressure instead of water. So after 5 months, back to operating room for the artificial iris implantation. So again, I just repeat the same concepts as before. So just a repetition, scleral fixation, 3 points. So I just prepare my 3 scleral pockets at 12 o'clock, 4 o'clock, 8 o'clock. And I prepare, of course, I prepare the sclerotomies at 2 millimeters from the limbus. And this is the wrapper artificial iris with IOL included. Again, the repetition of the steps that I showed you before. Prolene 10-0 with a loop. Now, in this case, since it was only 5 months after the PK, I just prefer to reopen the PK suture instead of create a new opening. So I just prefer to remove some corneal stitches, entering with the artificial iris through the corneal transplantation suture. And now I just position the last scleral fixation at 12 o'clock. And now I just put again the corneal suture of the previous PK. So this was my strategy, because the PK was very fresh. It was just 5 months before. And now I just centering the pupil. You can see the centration is very crucial, because before closing the suture, you have to be very careful to obtain a good centration. And now finished. I just closed the scleral pockets and the conjunctiva. So the patient was very happy because the result was good. My concern, my fear was about the cornea, because you know, cornea after corneal transplantation, the corneal graft can be weak, and after all these maneuvers, my fear was to have maybe a corneal decompensation, but fortunately not. The cornea was still transparent after 12 months now, 1 year after still transparent cornea, and ocular pressure is good too. So these are some publications about that you can find on PubMed, and we have many cases with different implants. So I just want to dedicate this presentation to our dear Ennio Morricone, that you know just died last week, and thank you for the attention.
Matteo, very nice cases. I share with you the I think that the video was excellent, and this iris implant is very nice. I'm a little concerned about the visualization of the retina after with those.
With the pupil. You
Yep,
mean
yeah.
the small pupil? Actually,
Yeah.
I can tell you that usually I always do vitrectomy with biome system, wide angle viewing system. And I can tell you that using biome, even with a narrow pupil like that, you can do a good job. I have, not today, but I have another video I presented in another Congress. And I just to show how can you do vitrectomy easily after artificial iris implantation. Of course, using the biome or RUV or IBOS, I mean, wide angle viewing system, because you know that it's indirect system and you just need a narrow pupil to see. So your question is a common question. I mean, many people asked it, but with biome, it's easy, yes.
Beautiful.
Soledad, ¿vos querías hacer una pregunta?
Beautiful, Matteo. I can't wait to do an like prosthetic. I have a few questions. So what were your challenges in terms of the power of the implant? I mean, what type of implant is in that model that there is the iris and the implant? What is the material? How do you calculate the power? Because are you calculating for the sulcus, for the back? And then how do you size the size of the, you know, like do you use white to white, and what were, you know, did you have any problems? Because, you know, surgery looks fine, but then after, you know, if the size is the power, you know, those can be challenges.
Excellent question, excellent points. So, number one, the IOL power, it's like sulcus, more or less, because you know, the plane, it's like the sulcus plane, okay? Of course, we are talking about severe ocular trauma. So maybe you can have a little, you can have a small error, but I mean, maybe, you know, minus 1 diopter, minus 0, okay, it's not a problem. But usually I think about sulcus position. And second, the material is silicone, so it's foldable. Okay. And very important question about the size. Okay, I like this model because of that. Because actually, you don't have to calculate. Because the diameter, it's small. It's like, maybe, I think it's like 10 millimeters. It's not big. Because as you saw, you have the circle, but then you have the three small loop, haptic, very, very small. And these 3 haptic are flexible. So when I pull my suture to obtain the final centration, actually I pull the 3 loops. So I can stretch the loop a little bit. In this way, the disc, it's in the center and leaves a space between the angle and the prosthesis. So you understand, it's not a huge prosthesis, it's smaller.
And this the leaflet, I think.
And then only the 3 loops touch the sclera. So you have a space for the aqueous, for the humor aqueous. So you don't have the fear to block 360 degrees. But this problem was very common before when I was using human optics. Okay, human optics is still good, the prosthesis, very good. of course. But human optics was exactly like you said. You had to calculate white to white because the human optics prosthesis is very large. And you have always, I mean, in the human optics guidelines, it's written officially that you have to measure white to white and you have to leave 0.5 millimeters. So you calculate white to white. For example, 12 millimeters. You cut 0.5 millimeters and then you have to trim with your scissors, you have to trim the prosthesis smaller according to the white to white because it's a circle. So for human optics, that was a big issue. You have to be very careful because if you didn't calculate well, you could implant a very large diameter and you could block the angle, you could have secondary glaucoma, endothelial decompensation, a lot of problems. Wrapper prosthesis, it's smaller and it's one size fit all. One size fit all. Because you understand, when you pull the suture, you stretch these loops.
Okay.
So you don't have to calculate anything. Okay.
Ike, what is your experience, Ike, with this kind of prosthesis?
Yeah, I think they have a great role. And I think, you know, Matteo, thank you for showing a challenging case to try to suture the iris. I usually say that if it's there, we can try to work at it. But that iris was very friable and synechial. And as you saw, there was, you know, bleeding when you manipulated it. So there's certainly a role. And even if there's iris tissue there, if there's a lot of thinning and transillumination defects, you can make the pupil small, but then too much light goes in the eye. And that's also a problem. So I think, you know, you displayed it very nicely, Matteo, all the different options available. Cost is often a factor. Human optics is a beautiful implant. We really enjoy it and love it. I use it in the bag even, or sulcus. I always make sure I suture it though, if I put in the sulcus, even if there's capsule support. I think it should be secured down into the eye. And I think that, you know, Raper and Morcher also have good products to use as well. So I like the Morcher products for in the bag. When there's a small localized area, you can slip it in there very easily to use. The modified rings, it's kind of technically the least demanding. And it can be placed into the bag like a cap retention ring. So I do like it for that purpose. And you showed many different suturing approaches. I do personally use Gore-Tex suture just because I worry long-term about proline, but this is a problem for access as well for surgeons to get availability. So, but Matteo, you have shown us a great number of amazing, beautiful cases and very challenging cases. So congratulations, it's very good.
Well, thank you very much, Ike. I agree with you. Morcher in the bag, it's a good solution because it's cheap and effective if you have a bag.
That's Matteo. One comment. I'll also use the Raper. I have a video similar than you. The only difference is a brown color instead of the blue and the green, okay, that you present, I represent. Just a small comment. The material is really a hydrophobic acrylic, okay? And also, it's like you say, it's just one size fits all. I think that's the advantage of this prosthetic, and I really like it. I use it many times, the Morcher and the Human Optics, but now I only use the Raper. That's true.
Yes, I think, I mean, Human Optics also, I did a lot of previous implantations, and I believe it's a great prosthesis. But maybe Raper now, it's easier for the surgeon also. It's easier. You don't have to calculate. You already have the holes to pass the suture. You can have IOL inside. Maybe Raper just put all the advantages together. Maybe.
Yes. I like also, just before go, Patricio, is to show you just for 2 minutes the same, okay, iris diaphragm. I think I can share. Basically the same, but here I'm going to show you just in small detail how to suture, in this case, iris. This change of color under the water, so you have to take care about the color. especially because it came in the box, one inside and another one diaphragm outside, just to see and compare for the patients, okay? It's like Matteo did, the same, again, but just take a look. At, now I'm using Nice0 Proline, okay? And you have the holes, perfect holes to do it. And just one more small tip is that when you implanting the two superior, for example, it's gonna be inside the eye, you're gonna cross the needle inside the eye, okay? But you have to not suture the last one, because the last one is the most difficult part to plant. So I can do is always suture the two superior, and then I left the last one for the last. Also,
me too. I leave the last one for the last. Yeah.
Yes, that's a, I think, good tip for people who like to start with this. This is foldable, like you see here, okay? And yes, you have to take care sometimes about this, but it's very stable. And then to suture, I bend the needle. In this case, it's a Nice0, I think, a straight needle, and then I bend it, and it's easily to then make the knot there, okay? And like Matteo said, also it's very important the position of the iris must be, in this case, behind the original one, okay? Remaining iris that you have, and that's it. So I like now is to, I think, Vicente, we have 2% to Patricio, right?
Okay.
Yes.
Yeah. I agree totally. We have the same technique, basically.
Yep. Yeah. Well, in this case, I would like to present to Dr. Patricio Grayet. Patricio is very good friend of us for many years, and also he's the chief of corneal refractive surgery department at the Hospital Oftalmológico Santa Lucía in Buenos Aires, in Argentina. He's also director at Zimmer 2000 company and is professor of the University of Buenos Aires. Patricio, you can present now. Thank you so much.
You're a good friend also. I'm very pleased to be here with all these great surgeons. Well, I will talk about my experience in ocular trauma in patients with post-LASIK. Usually, when there's a blunt trauma, you will have a displacement of the flap. And this is very easy to see at the slit lamp, as you can see here in this video. But sometimes things are not so easy to, as in that case. So you may need to do a retroillumination in order to see small wrinkles or microstria affecting the visual axis that may produce some irregular astigmatism. Also, you can be helped with fluorescein staining, or also, if you want, you can dry the surface with a microsponge, and that will highlight small irregularities of the surface. So if you don't realign the flap immediately, you may have irregular astigmatism, epithelial ingrowths, or corneal melting, and even infection. So when you receive a patient with pain, photophobia, with the classic symptoms of flap dislocation, you also will have perhaps some dysphotopsias like monocular diplopia, halos, and glare. And it's very common to, if you do ARM readings, this will be very unexpected and variable. And the treatment depends when you receive the patient. And if the trauma was in a few hours before, it's very easy to realign even at the slit lamp with a cotton tip. You can realign the flap, and perhaps that's the end of the story. But if 12 or 24 hours after the trauma has passed, you will need to take the patient to the operating room and perhaps lift the flap, flashing the interface with BSS, or sometimes when you have folds, you will need a hypertonic solution in order to swell the flap, and that will help a lot to get rid of those folds. And sometimes I prefer to take to remove the epithelium, and that's a good point to get rid of the wrinkles. And in case you have any epithelial ingrowth, you have to do some scraping with a blunt instrument of the surface, the back surface of the flap and the stromal bed. And I like to use 20% alcohol solution in order to kill any possible remaining cells of epithelium that will produce perhaps a recurrence of the epithelial ingrowth. And in severe cases or in cases of recurrences, I prefer to perhaps to be a little more aggressive and do a suture of the flap or use fibrin glue. And in very difficult cases with melting of the cornea, you may perhaps need to amputate the flap and perhaps program an anterior lamellar keratoplasty. The case I will report today is about a young man that I did with Dr. Weinberg, a myopic LASIK 1 year before. He was very happy about that, but unfortunately he received an impact with a tennis ball in his best eye, and he came really very in pain and desperate to our office. And he, as it occurs only 1 or 2 hours before, I could easily realign the flap. I put a bandage contact lens, and I thought that everything would be end there. But the poor guy develops all the possible complications you will imagine after a blunt trauma. He got a glaucoma because of an angle recession. He got edema, iris damage, subcapsular cataract, sonular damage. He was rid of traumatic maculopathy and got rupture. But after 2 months, he develops a retinal detachment. And he needs 2 vitrectomies to attach the retina. And perhaps because of the maneuvers during the vitrectomy, remember that retinal surgeons need most of the time to remove the epithelium, and that could produce some displacement of a flap. So I received the patient in this condition, as you will see here. The flap, here is the case. You see the dysphoria, and the flap is almost loose. So as he was a little tired of ocular surgeons, I thought that the best way to avoid an extra surgery was to suture the flap. So you see here how easily is lift the flap. He's almost floating because of the epithelial ingrowth underneath the flap. You see there the epithelial ingrowth. And so I have to scrap the surface with a blunt spatula. I didn't cut the epithelium, I retracted to the periphery, and then I told you why, and then you have to clean also the back surface of the flap, and obviously you need to put some alcohol there to kill the remaining cells. You see here how there is a little melting at the end of the flap, and so I decided to do stitches, radial stitches like a lamellar keratoplasty. And with that, you avoid a new recurrence of the epithelial growth that may produce corneal melting, and also you can get rid of any wrinkle that produce irregular astigmatism. So to help the epithelium to grow in the correct direction, I put the retracted epithelium over the flap, like you see there. And that's a good point to avoid that. And then I remove any necrotic epithelium to enhance the healing of the epithelium. So for the poor guy, things went very well after this, but he continued with additional surgery because of his cataract and his subluxation and his glaucoma surgery. So I put a bandage contact lens, and you will see the result after 24 hours that it was very nice with no epithelial ingrowth, and after 30 days things continue to be perfectly. So remember always to use the proper eye protection when you practice in sports. Thank you.
Gracias, Patricio. Todo muy bueno. Any comments? Federico, Gerardo, Mateo, I don't know.
Bueno. What is your technique, Patricio, to prevent, let's say that this patient will have a recurrent epithelial growth. You will do the same, will you add like some, like mitomycin or something else to prevent? Because this was perfect, but that's not common, no?
Yeah. No, I think that the last thing to do is to suture the flap or use glue to avoid recurrences. I don't know, Luis, if you have ever done that.
Yes.
I never had the opportunity to use glue, but I have a good experience with stitches.
Okay.
But,
yeah. Yes. We used to use fibrin glue, okay, and we put only in the just external, and especially in after trauma, we put that, and with a soft contact lens. We wait a lot, maybe 3-4 days, and with good results too. So it's another option to use fibrin glue in cases of recurrence of epithelial ingrowth, and especially after trauma. Yes, I think it's a good option too.
Yes, I think that the important point is that you have to act quickly. You don't have to wait The flap will always be dislocated. It never will by itself go to the original position. So you have to not to wait in these cases to avoid complications.
Patricio, there is one question here. How long will you leave those sutures? Usually,
not so much. You only have to wait from the epithelium to grow in his original position, and then you can remove it whenever you want. I prefer to leave them for about 2 months. In this case, we have to wait 2 or 3 months for the cataract surgery, so to calculate the lens, we have to remove all the sutures.
Any other comments?
Yes, be careful of your opponents playing tennis. Wisely. I was thinking who he was playing with, Serena Williams, because
no. You're gonna blow your head instead of your eye.
it was like.
Ok, Erwan, ¿algún comentario más? ¿Estamos bien?
Yeah.
I think that you're okay.
Okay. Well, thank you guys to everyone. Really, thank you especially to Patricio. He organized everything. So thank you so much. And also to Vicente. And I think for Mateo, it's going to be buonasera. Huh? Thank you so much, Mateo. Thank you so much, Romero. And Ike and Gerardo. Okay. We are always in our heart. Gracias a todos.
Gracias a ustedes.
Thanks so much.
Ciao, Ike.
Guys.
Ciao,
See you.
everybody. Take care.
Gracias, Vicente, por todo.
Bye.
Thank you, Soler.
Gracias, Pato. Love you. Bye.
Ciao.
Mateo.